Good afternoon, and thank you all for joining us at our Schwartz Center's virtual Compassion in Action Healthcare Conference. We are very, very happy that you've chosen to spend your Friday afternoon with us, and we have a wonderful session today. While you're listening, if you have questions, please do feel free to enter them into the Q&A box there, the little pane, and we will address your questions at the end of this discussion. And now please join me in welcoming Roshi Joan Halifax. Roshi is a Buddhist teacher, a Zen priest, medical anthropologist, and a pioneer in the field of end-of-life care. She's the founder, abbot, and head teacher of the Upaya Institute and Zen Center in Santa Fe, New Mexico. She's also the director of the Project on Being with Dying, and Roshi has lectured on the subject of death and dying at many institutions and medical centers around the world. She's also the founder of the Upaya Prison Project that develops programs on meditation for prisons, and she is the founder of the No Man's Clinic in Nepal. Many, many wonderful programs and things to listen to. So welcome, Roshi Joan Halifax.
Thank you so much, Beth. It's a real honor to be sharing some of this work that I've been engaged in with people at the Schwartz Center. I'm really, really grateful. And I chose this date intentionally. One, in part because I am, like all of us, profoundly aware of the inflection point that we're experiencing in our country at this time in relation to medicine, health, poverty, race, and the pandemic. And Juneteenth is a day that has been marked by Afro-American people as the real day of emancipation from slavery. Interestingly enough, it was on June 19th in 1865, which was 2.5 years after Lincoln offered the Emancipation Proclamation. Union soldiers arrived in Texas to report that the Confederacy had surrendered 2 months earlier, and that all those who were slaves were now free. So I want to just take a breath as we move into this talk, but to drop into this recall of how much suffering so many in our country have faced and are facing on this very day. And to realize clearly that compassion, as His Holiness the Dalai Lama has said, is not a luxury. It is a necessity for human beings to survive. So I'm going to request that we take a deep breath and on the exhale, dropping into the body. And remember really why we're here. I mean, we're here because all of us in one way or another serve others, and we endeavor to help alleviate suffering. And this talk that I want to offer today is about compassion. And maybe in opening up the talk, take a few moments to bring to mind someone who's really suffering at this time. And allow yourself to connect. So much of this work is about how we connect with each other. And are we open to the truth of suffering as it is? And recalling the situation of this person. See if you can allow yourself to wish the best for him or her, and to affirm that you're in this work of serving others from a foundation of compassion. So thank you. It's just a pulse, really allowing ourselves to get grounded, letting go of external distractions, and recalling our intention, our motivation, our aspiration to transform suffering, to end it. And yet we know, those of us who have anything to do with the healthcare field, that healthcare providers are profoundly challenged today. And without realizing it, that Beth was or was related to Bernard Lone. I actually am beginning to talk with a quote from Dr. Long. And this was a quote that actually I found in the New York Times. I think many of you know the book, The Lost Art of Healing, which is an appeal to restore the 3,000-year tradition which bonded doctor and patient in a special affinity of trust. The biomedical sciences had begun to dominate our conception of healthcare, and he warned that healing is replaced with treating, caring is supplanted by managing, and the art of listening is taken over by technological procedures. And it is not to say those features aren't important in the delivery of medical care. But I think what Dr. Lon is pointing to is the importance not only of cure, but also that cure is accompanied by care. And care is expressed in the process or the experience of compassion. And I thought it might be helpful to touch into a little bit about compassion as we begin to unpack compassion in the United States in relation to the pandemic that's being experienced right now. And this is a simple definition of compassion. It's the emotion one experiences when feeling concern for another's suffering and desiring to enhance that person's welfare. And this is from the work of Leiberg and Tanya Singer and her colleagues. And then from this point of view, compassion is considered to have two main valences: the affective feeling of caring for one who is suffering, and the motivation to relieve suffering. So I became very interested in compassion, first as a medical anthropologist in the 1970s, where I worked at the University of Miami School of Medicine, and saw when I was there that the most marginalized people in the healthcare system were dying people. And also later, after my experience working in that clinical setting in Jack's Memorial Hospital, consulting all over the hospital, it's really powerful experience in teaching medical students. I worked with Stanislav Grof on his project with dying cancer patients. And what I began to see is that compassion was actually profoundly beneficial. Not only for those who received it, but also for those who experienced it. But I also saw that our view of compassion was compromised. And I began to, over the years, as a person who was training healthcare providers and also as a contemplative, began to unpack what compassion is in a more direct and simple way. And I want to mention 4 features that I think are very important for us to keep in mind because they relate to how we train clinicians or healthcare providers or those who come alongside those who are gravely ill. And the first quality is having the capacity to actually attend to the experience of others. So here, compassion involves presence. It's that capacity to connect, to be grounded, to be non-distracted, to be able to release external distractions, and to give or allocate your attention completely to the one who's suffering. Compassion also involves our capacity to actually feel concern for others. I asked myself when I began to do more granular research on compassion, if it was possible for a person to be compassionate who was basically antisocial, who wasn't pro-social. And clearly compassion involves a deep sense of prosociality, involving experiences such as care, concern, loving kindness, and so forth. But compassion also involves the capacity to actually discern what might serve the other. And I think this is a very important component of compassion. And that discernment comes about in part through our capacity to have what is called attentional balance, a quality of presence which is non-distracted, where we're able to allocate our attention for longer periods of time than just a mind moment, where attention is not divided, not distracted, not dispersed, where also non-judgmentality is present. And that discernment process involves something else that is kind of unusual. One is, of course, our past experience, including what we've learned from books or mentors or our interaction with patients and so forth. It's important. But being able to discern deeply means also being able to rest with a quality of heart and mind that's very open, and where there's a clarity of perception, as I said, that's non-judgmental, but is characterized by openness or not knowing. Yeah, it's pretty hard for us Westerners to actually rest in that quality of mind, because so much of our identity is wrapped up in our expertise. But this openness is really important. Then the fourth quality is potentially to be able to serve. And I say potentially because the intention or the aspiration for the alleviation of suffering is there, but we're not always able to do something directly. And I think about the image that my friend Mathieu Ricard, who's a long-time contemplative, gives of, there's somebody in a small airplane, it's over the ocean, and they look down, they see, oh, somebody's thrashing in the water, drowning. And there's nothing that the person in the airplane can do to actually help the person in the water. But the person in the airplane sees a fog bank 100 feet away actually covers an island. And so there's this deep feeling rising up. May this one find his or her way to safety. That also is compassion. So our work in this field is very interesting because it involves some elements that I think are very important for us to look at. And, first, our work is about alleviating or creating the conditions for the alleviation of suffering and or pain for those who are ill. And certainly that is the imperative as healthcare providers face what they're facing in relation to the pandemic. And also, one of the powerful things that we do as people who support healthcare providers, like chaplains, but also patients, we're also there to work with the suffering of family and friends. We're not just working in a vacuum or just in a dyadic experience or an experience just with a team. Also, family, friends, those who are in relation to the dying person or to the person who is seriously ill. And there's a third population, and we're included in that population. And that is where actually we need to address the suffering of healthcare providers, of clinicians, of those who are on the front lines. And we know at this point that clinicians are facing, who are working in the pandemic, extraordinary challenges. And even prior to the pandemic, clinicians were facing enormous obstacles. For example, in one survey, more than 60% of physicians report symptoms of burnout. And this includes the experience of being emotionally completely tapped, total emotional exhaustion. Also includes the experience of depersonalization, of basically treating patients like an object, of the objectification of patients. And as well, and I'm sure this is very much present for many clinicians today, and that is being faced with a low sense of accomplishment, of not being effective, not being able to really serve adequately, not being able to save lives, not having the adequate equipment to protect themselves and to serve their patients. And we're also aware that even in medical school, there's reports of extreme burnout and also of self-harm. So one of the things that I began to look at, realizing that compassion, though in the nursing profession was valorized, but often there's even a compassion deficit among nurses, but certainly among clinicians, doctors, physicians, compassion is not necessarily so valorized. I began to look at some of the virtuous or important qualities that we need to actualize in our care of others, that qualities that are profoundly valued, but which are not also so well understood, and particularly in relation to the expression of these qualities in the shadow form. In other words, in the form that they appear when not wholesome, but in fact toxic. And as I began to explore what I have called edge states, these bivalent experiences, what I realized as my exploration became more granular was that there was one way to actually transform the negative valences, the toxic expression of edge states into the positive expression. And that one way is compassion, but it's not idiot compassion or sappy compassion. It is compassion that involves the qualities which I was speaking about earlier, that is are developing really the strength of presence that allows us to bear witness to the truth of suffering in the midst of conditions. Not shutting ourselves off, but actually having the heart open, having ourselves emotionally sensitive, but regulated so we feel genuine concern about the well-being of others. And that as well, to have the aspiration to transform the suffering of others through clear discernment. I'd like to speak for a few minutes to some of these edge states, and I'm very glad that Dr. Cinda Rushton, I believe she'll be speaking next week to you all around issues related to moral suffering, because it's in this suite of features, but I think Cinda will do a deep dive into moral suffering. And I just want to outline some of the features that Cinda has identified and Cinda and I have worked with. But the first edge state that I want to speak to is altruism. And altruism is that experience of selflessly serving others. And it could involve some degree of sacrifice of various kinds of physical well-being, of mental well-being, and so forth. But when the sacrifice goes into an extreme, this is called pathological altruism. And this is the experience of physical or psychological harm to oneself by placing the needs of others above one's self, above one's own well-being. And this is a very interesting geography, because it's a slippery geography. And often I tell the story of Wesley Autry, who is an Afro-American man on a subway platform in New York, who standing with 100 other people, including his 2 young daughters, they all saw a man, young guy, having a seizure and throwing himself unconsciously into the subway tracks, and Autry just leaped off the subway platform in order to save the man's life. And the subway train was coming really fast, and Autry realized he couldn't drag the man, whose name was Peter, couldn't drag him out of the subway tracks. And so he held Peter down, and the subway passed right over their bodies, grazing Autry's knit cap, and both of them survived. So that was deemed by many people as an act of extraordinary altruism. But it would had Autry and or Peter not survived, it probably would have been deemed pathological altruism. So as I'm saying, there's not a clear margin here, but it's very helpful to understand how many of us, how important it is to put often the needs of others above our own needs, by the same token to cause serious damage to ourselves, psychologically, spiritually, economically, relationally, physically, adds to the bigger quotient of suffering. So pathological altruism, edge state, very interesting. And then empathy, one of those qualities, usually very prosocial, where we're in somatic, affective, or cognitive resonance with others. You're sitting with a patient, or I myself have had sepsis, and the then was, of course, hospitalized and was gravely ill. And I just remember how the nurses and the aides took care of my body during times of high fever or racking chills. And I could really feel the empathy of my caregivers in this experience. They were in resonance with me. I wasn't being handled like an object. I was being touched, moved, turned, cared for, like a human being. But actually, it was more than just like a human being. I felt their motherly care very deeply. And it really came from this experience of them being in resonance with me. And I can say, as the patient, I also had resonance evoked in me toward them. So there was this mutuality, which is a very important feature in the work that we do. And yet, empathy that is not regulated can produce experiences of vicarious suffering that are really unsustainable. And again, coming back to the healthy expression of empathy, I often say a world without empathy is a world where we are dead to each other. And by the same token, a world where we're vicariously suffering because of all of this sort of massive horror that is happening in our society at this time. And even thinking, of what ER doctors are experiencing in not having adequate equipment or being able to really serve their patients or bring family members in to say goodbye. It's overwhelming for many, and at times also for me. But the regulation of empathy is really important. And one of the ways that we regulate empathy is through a kind of meta-aware, metacognitive approach that is our capacity to be in resonance, to have some degree of upregulation, but also to understand, to see clearly, I am not that person. I'm not the person in the hospital bed. I'm not that family member. Yes, I'm connected. I'm in resonance. But compassion shows the way for that capacity, that deep discernment or that insight into the distinction between self and other. The third edge state that I'd like to address is that of moral suffering. And when I was working on this, and I have to credit Cinda Rushton, who's my great friend and colleague for many, many years. We've taught together so many times, and I just have learned tremendously from her. What I realized is that moral suffering is one of the really important experiences for us to identify and also to understand the value of integrity. And in our work as caregivers and the cultivation of insight around our experience of integrity is so important, because when we're out of alignment with integrity, the experience that arises is that of moral suffering. And moral suffering is the harm we experience in relation to actions that transgress our tenets of basic human goodness. And it manifests in at least 4 main forms. The first is moral distress. And I feel that many of us are in that soup right now. Moral distress has been defined as the pain or anguish affecting the body, the mind, or relationships in response to a situation in which the person is aware of a moral problem, where also he or she acknowledges moral responsibility and makes a moral judgment about the correct action, yet as a result of real or perceived constraints, participates in perceived moral wrongdoing. I want to read that definition again because I feel many healthcare providers are in the grip of moral distress at this time. So moral distress has been defined as the pain or the anguish affecting the mind, the body, or relationships in response to a situation in which the person is aware of a moral problem, acknowledges moral responsibility, and makes a moral judgment about the way forward or what is the correct action. Yet, as a result of real or perceived constraints, participates in perceived moral wrongdoing. Further, moral distress arises when we're aware of a moral problem and we determine a remedy, but we're unable to act on it because of internal or external constraints. And I think this is something that, I feel right now that moral distress is rampant, not only in relation to the pandemic globally, but as well to our political situation. So we can ask, can moral distress ever serve? And it can. It's not just a sinkhole, a unidirectional gravitational surface, and there's no way out. It's actually a wake-up call. It's a powerful message that there's a lack of alignment with our values. And I think it's important to understand it's a wake-up call, but if moral distress becomes chronic, it harms us. Because being polarized and aroused chronically puts us in a state of stress that can have serious physical consequences, psychological consequences, and as well social consequences. Yeah, moral distress. And then moral injury is the next category I want to briefly address. It's defined as the psychosocial and spiritual burden caused by an act that goes against one's own or shared morals and values. And it is a psychological wound resulting from witnessing or participating in a morally transgressive act. Moral injury is a toxic mixture of dread, of guilt, and shame. So moral injury has been primarily identified in the military. But in my own work in serving clinicians, it is a more and more frequent subject that is brought into focus by clinicians who feel that they're working in a system that is not responsible and responsive, where they see other clinicians doing things that they feel are unethical or causing their patients to be harmed. And that the issue also of moral injury arises in relation to what's called structural violence. That is how our systems are organized with maybe not the conscious intention to harm others, but where others, whether by virtue of race, gender, age, and so forth, are subjected to moral and direct harms. So we're in that stew. So the next category that I want to speak about in the world of moral suffering is moral outrage. And, you know, just as moral distress, moral injury, and are so frequent but unacknowledged in our lives as providers of support or healthcare providers, moral outrage is also operating at full tilt. And this is an externalized expression of indignation toward others who've violated what we feel are the correct norms of our society. And it's an experience or reaction that involves both anger and disgust in relation to actions that we perceived as profoundly unethical. Now, again, as I said about moral suffering and moral distress, it's a kind of wake-up call. Moral outrage is often just that sense of self-righteousness or outrage is enough to actually precipitate actions that are transformative in that benefit patient, family, institution, and oneself. But chronic moral outrage, you know, it's the kind of meme, if you will, that we operate out of is totally separated from anything that we know of as compassion. And it becomes the filter through which we perceived everything. And the last category in this geography of moral suffering is moral apathy. And honestly, I had not thought about this, and I think that just showed me at the time, wow, that's a blind spot. And this came to my attention when I saw the film about James Baldwin called I'm Not Your Negro. And he used the term moral apathy. And I thought, oh, got it, to the extent that I get it. But it is when we simply don't care to know, or when we are in denial about situations that cause harm. And moral apathy can come about through addictive behaviors, or be because we're in bubbles of privilege, or we've simply dumbed down or numbed down so that we've lost our capacity to perceive the harms of this world. So I feel like this is really important content for us to address as we begin to evolve the geography of pitfalls in relation to how we give care, and also our capacity to develop moral character as we move into this world of deep suffering. So the two other areas that I've addressed as edge states include respect and disrespect, and how important respect is of oneself and others in relation to the care that we give. And that to understand that respect arises out of the internal beliefs that we have about the value of others, of human life, of all species of this earth. And it also arises out of the deep acknowledgement of sharing a common life and a common destiny, and feeling esteem or appreciation for others. But disrespect is a really toxic aspect of the edge state of respect. And it involves two vectors. One of those vectors is what's called horizontal hostility. And that is the behaviors that we or people engage in that either controls or devalues, disrespects, diminishes, disparages a peer or a group of individuals. And I actually hadn't heard about horizontal hostility, though I was a feminist in the 70s, and Florence Kennedy talked about it. Somehow it didn't stick in my brain until one of my students, who's a nurse, brought it to my attention through a thesis she wrote in our chaplaincy training, that how many nurses leave the nursing profession because of disrespectful behavior between peers. And then there's the vertical axis. That is, that axis has a top-down aspect, and that top-down aspect refers to power and control. So for example, if a physician treats a nurse disrespectfully, or a nurse treats a patient disrespectfully, or a bottom-up dimension, which is, I remember I teach in Japan often, and I teach in hospitals in Japan, working with a group of nurses in a palliative care unit in the Fukui project, where a male patient was really abusive of the nurses on that unit. And they were completely traumatized. They felt stripped of their dignity. So vertical violence can be top down, or it can be bottom up. And then burnout, which I spoke about earlier, which is, working in a context that is fundamentally toxic, or where the cumulative work demands are impossible to be met, or where the work is fundamentally meaningless. And the opposite, of course, the healthy aspect is engagement, being deeply connected to our work and to feel the sense of meaning in our work. So these are the edge states. Much is to be said about all of them. I have a few minutes to complete this talk, but only to say two things that I want us to keep in mind. Just because we find ourselves slipping over the edge into these territories that are unwholesome, unhealthy, toxic, challenging, our capacity to kind of climb out of that hole, it really builds character. And I think that we have to keep that in mind, that we are constantly falling over the edge, but it's exactly this kind of moment of inflection where we recognize that we're in the mire, we're in the grip of deep negativity, and what are we learning? What can we actually retrieve from that experience that will engender not only humility, but also a greater capacity to care? And the second thing that I think is really critical is that the cultivation of compassion, about which I began the talk, is the, if you will, the pivot or the lever that can transform these edge states, the toxic side of the edge states, back into their healthy expression. Because we are able to bring attention to these experiences and not turn away from them. Because we feel concern. Because we have the aspiration to actually end suffering, our own and others. And then we take actions, committed action, to transform either ourselves or the conditions in which we are serving. So it is now 45 minutes since I've been talking. I pledged to finish in 45, and I hope I have met that promise. And I just want to say thank you, and I'm very open to answering questions at this time.
Thank you so much, Roshi. That was really profound. And I do not think that I've ever heard the edge states that you speak of explained so clearly. We had one question, then I'm sure there'll be others, but this participant wonders if you have suggestions about ways to address the moral distress our nurses are feeling as they describe their fear that working under the present conditions are putting COVID patients and themselves at risk.
Yeah. I think one of the most important first steps is actually in the question that you've asked, and that is to acknowledge that the suffering is there. Not to acknowledge it is to drive it deeper into the collective and also into the individual. And so it is taking, if you will, time out or times out from service, where we can bear witness to the truth of what we're struggling with as people who are in the world of caring for others, but overwhelmed by that world and overwhelmed by the lack of support. So that's one thing I think is important, is the initial acknowledgement. The second thing is, and to understand how important our relationships are in these circumstances, whether it's the relationships between team members or between those team members where safety is present, relationship between administration and the interprofessional team, or to, as a clinician, as a caregiver, to have relationships outside of the clinical setting that allow for the kind of spacious holding where that suffering can function in a positive and transformative way. Another approach, of course, is the contemplative approach, and that's working with the development through contemplative processes or practices of attentional balance, cultivating emotional balance, cultivating meta-awareness, metacognition, so we're able to not just be a toy of our circumstances, but to have a metacognitive perspective, realizing this ain't gonna last forever. So you have wisdom that you're bringing forth. Another thing is a very clear and determined commitment to good physical, mental, and relational care. You know, just being completely, unabashedly altruistic and sacrificing yourself on the altar of service is of no service to anyone. And it is to have clear agreements, clear boundaries, including with yourself, about self-care. So those are just a few suggestions. I hope they're somewhat helpful. And I know that in the lived experience that frontline clinicians face at this time, these suggestions might be difficult to actualize, but maybe there's a way that a piece of one or two can be of service.
Yes, thank you. We have another question. Many nurses talk about the anger they are feeling as people in the community disregard safe practices, which put the system at work, puts the system, at greater risk. How to work constructively with the anger to move out of this sense of outrage.
Yeah. So one of the things that I learned working in the penitentiary system, I was a volunteer on death row and maximum security for 6 years. And talk about anger. These are institutions that are anger breeders. So I really studied anger, not only in the institution, but also in myself. And I made a kind of dumb but significant discovery. And consistently, anger was associated with a feeling of helplessness. And when I saw that, things began to shift. And I too feel helpless. I see, I'm quite quarantined right now, but I have to go out a little bit. And when I see someone without a mask, I feel that anger. It is a threat to my survival. And how do we work with that? I think one of the things is to understand that anger isn't all bad. It's coming out of helplessness, but also it has clarity often within it. And when we divest the narrative from the emotion, and we find, if you will, the beneficial quality of anger, which is clarity, we can often find a pathway to communicate to others more skillfully and with less polarization in relation to what we feel are not only moral violations, but physical violations. But I just want to say, I hear you. And I'm also in that myself.
Thank you.
And, my salvation is my practice, I have to say. Having a little bit of meta awareness going, working in the prison system really taught me so much about anger. And also I know cause and effect. Boy, if I blow up at this situation, it's just going to harden up the other party. And the outcome is not going to be good. So I begin to work it in that way.
That's wonderful. More questions. We have still some time, and there are questions coming in that are wonderful. Any insights or thoughts related to the language of victims and heroes in healthcare? Can you share your ideas about how this might evolve in a way that might heal our environments?
Gosh, I would actually have to, it's a great question, but I could take it in too many directions. So for me, often victims are the clinicians, not just the patients, if you know what I'm saying. And the heroes are not only the clinicians, but also the patients. I think in a way, even those categories could be problematic. If you know what I'm saying, that it puts the onus of a kind of identity of power and powerlessness in relation to both clinicians and patients. Clinicians and patients are in a relationship of high mutuality, just like administrators and clinicians are. And how do we, build bridges where there's not the sense of disempowerment and victimization? And often when these terms are used, I think of Stephen Karpman's trauma triangle of perpetrator, victim, and rescuer. So the two categories that you brought up are hero and victim. So be like the rescuer and the victim, but they're also the perpetrators. Because where there are victims, there are perpetrators. And Karpman's very interesting thing about the trauma triangle is that those identities and roles actually shift, where the patient will feel like a victim and then come after the clinician by taking the role of the perpetrator and so on. But maybe I've missed the point of the question a little bit.
Well, it's hard to know exactly without, asking the person to clarify, but I do think that there are many clinicians who really object to being called heroes. Everybody's standing on the balconies or thanking the clinicians, and I think many feel mixed about that. On the one hand, I think many feel that they would prefer to have the resources and the guidance and the equipment and the people that they need don't call us heroes.
Ah,
Please, give us what we need. Help protect us, so we can protect and attend to the patients. And in that sense, I think you're right about the merging of the concepts of heroes and victims. I think it's felt and it's embodied, I think, in people who are working actively taking care of the patients who are suffering in the pandemic.
Beth, thank you. I think that's what the person who asked the question really was pointing to. Yeah, thank you. I think your answer really serves.
I think it's hard. There are lots of questions now coming in. One person asks about contemplative approaches and practices that you have found for people who are resistant to formal meditation to develop self-regulation and attention. This is a good question because it is a
great question.
problem.
So it's a great question, and I'm glad somebody asked it. When I was doing this research on compassion, I developed a heuristic map of compassion, which laid out, if you will, what I perceived to be the geography of compassion. And it was really based on my contemplative experience, but also the work in social psychology and neuroscience. And and I essentialized it into the 4 aspects I talked about at the beginning. But and then it became much more elaborate and complex. The mapping did, of course. But what I realized was I needed to develop a tool which clinicians could use, which was non-sectarian, which could be used in vivo, which was about how one can cultivate compassion while directly interacting with someone who's suffering. And just briefly, that tool is called GRACE. And it involves 5 different aspects. And it's not, what could I say, sectarian, thank goodness. And it's oddly enough been taught all over the world. There's even a national GRACE organization in Japan, which is really amazing to me. But it involves the G of GRACE is for gathering your attention, is getting grounded. And the R of GRACE is recalling your intention. And the A of GRACE is attuning first to yourself, physically, emotionally, cognitively. Really check in where you're at. You can do that in an instant. Before you attune to others, before you bring the experience of others into your own subjectivity. So often, we're diagnostic, we're doing the opposite. We forget ourselves, we are already dropping people's experience into boxes and not knowing that our biases are actually shaping those boxes. So first attuning to oneself and then attuning to others. This is empathy, the A of GRACE. Resonance, somatic, affective, cognitive attunement. The C of GRACE then is consider what will really serve. Just taking that pause, looking deeply, being grounded, remembering who you really are and why you're there, being subjectively attuned and also attuned to the other, so that whatever you're discerning is not coming from biases or fear or institutionally driven, but is really coming from insight. Then the E of GRACE is engage from a perspective that is deeply considered. And the second part of the E of GRACE is end. How do you complete each interaction with some kind of internal or interpersonal acknowledgement, with appreciation, with regret, forgiveness, gratitude, so that you can complete the interaction and then move on. So we teach this to people in not only the medical sector, but in the business sector, education, and so forth. It's, you know, as I said, it's just this very clean, logical, but it's all based on contemplative practice.
Yeah.
Our capacity to perceive what is happening at the level of attention, intention, our capacity for resonance or attunement, our capacity for insight, and then engagement and completion, ending.
Roshi, there are many people, and myself included, I have read your books and about the GRACE model, but I think many people who are listening would like more information about where they might go to review some of your terms, your wisdom, your teachings.
Thank you, Beth. It's so kind. So I've written a book called Standing at the Edge, and it goes through, you know, much of what I've shared in our meeting today. Also, we produced a really beautiful online training, which is Upaya Unteachable, which is a deep dive into grace, and Cinda Rushton, Dr. Tony Back, and also Al Kazniak contribute to that teachable course. And, you know, Upaya is a place where clinicians have come for now 30 years. And what's happening right now, we're doing everything online, and we will for, I think, quite a while. But in any case, we have a lot of content free available that I think can be of service to others.
That's wonderful.
Thank you so much.
Thank you. Thank you, Roshi. We just, you know, I've been wrapped, just really so appreciate your words today. I've learned a lot. Thank you so very much. We do have to close, I'm afraid, but I do also want to thank the audience. And I hope you all will keep a lookout. We will put out a recap of this week's sessions, and it'll contain a link to CME, a CME post-test for the sessions. And we look forward to having you back on Tuesday for Community Building in Crisis, Evidence-Based Models to Foster Connection in Your Clinics, which is a workshop with Elizabeth Metro from Women Writers in Medicine and Curtis Mock from Optum Care. So again, thank you so much, Roshi, and thank you to all who are listening. We appreciate your attention. Have a good weekend.
Thank you. Bye-bye.
Thank you. Bye.